Hello, Joyce and classmates. We are Group 7, Israel, Ain, Dea, Christina, Cielo, and Leslie, and we are going to present to you about the mental health issues in the prison population. First, we want to give you an overview of our presentation. We are going to present to you the history of prison psychiatry and the causes of mental health issues. We will also show you the Canadian corrections and the delivery of mental health services in prison, followed by the future directions and treatment initiatives in Canada, and finally the conclusion and recommendations.
Everyone, my name is Christina and I will be presenting to you the history of psychiatry in prisons and causes of mental health issues. Before 18th century, houses of corrections and gaols were regulated by local justices. They describe it as filthy, corrupt, and unhealthy. It consists a huge number of prisoners with pending sentences of fines, death, corporal punishment, and prisoners to be transported to the American colonies, as well as mentally ill offenders. The bridewells appeared to be crowded and offensive because the rooms were occupied by lunatics. Some jailers were also corrupt in a way that they were paid by prisoners for food and drink, and they would accept bribes to release inmates and to take chains off. In 1556, there was an early attempt of reform in the House of Confinement. The reform was intended to lessen the level of corruption, with an act of 1609 introducing them into every country. Initially, it was successful, but the purpose gradually disintegrated. Between 1800 to 1966. In 19th century, there is a growing interest in applying scientific principles to the prisons in terms of punishments and rehabilitation. Prisoners should be cured for their criminal tendency. An increasingly number of prisoners will have mental disorder. The Criminal Act 1800 formalized that the verdict will not be guilty for reason of insanity. The County Asylums Act 1808 suggested to build local asylums which will also be the house of mentally ill offenders. The Insane Prisoners Act 1840, there will be 2 doctors and 2 JPs to confirm if the prisoner was insane before they transport them to the asylum. And due to the increased number of criminally insane in the county asylum, in 1863, the Broadmoor Hospital was opened to take mentally ill prisoners. However, the hospital does not accept male insane convicts from 1874 until 1880s. Instead, they have been sent to a wing at working prison. Life in prison according to Sir Edmund Duquesne, who was the chairman of the directors of convict prisons and the Commission for Local Prisons. He observed places of punishment, not rehabilitation. Because of this, there is high death rates in the prison due to starvation and exhaustion, and also high suicide rate. Is to health and education in prisons. There is approximately 70% of prisoners will have substance misuse problem on entering prisons, but 80% of them will not have contact with drug treatment services. Suicide and self-harm are the primary concern in the prisons. Educational programs have changed. Most of the establishments are in 3-year contracts through a commercial tendering process with budgetary control from the Learning and Skills Council. For these reasons, majority of the prisoners will gain poor school experiences, and some of them will end up with poor basic skills. However, since the learning and skills is focused on the basic and key skills. Therefore, the delivery of qualification over the past recent years are remarkable. Changing population. Between 1995 and 2005, men in prison serving 4 years. The change of the sentencing pressures on the prison estate. England and Wales have the highest count of life sentence prisoners in Europe. As this population rising up in numbers, the government is dealing with the pressure on the prison estate by building more capacity. In early 2008, the government declared its intention to build 3 supersized prisons that could accommodate about 2,500 inmates each, and have been replaced plans for privately run supersized prisons that could accommodate 1,500 prisoners each in April 2014.
Good day, everyone. I am Cielo Pipino, and I'm here to discuss the Canadian corrections. To have a full grasp of the Canadian corrections, let us look at its geopolitical context. The development and delivery of Let us now discuss these 2 federal agencies. The Correctional Service of Canada is responsible for the custody and care of all federal offenders and their supervision in the community. It comprises of 54 penitentiaries, 17 community correctional centers, and 21 parole offices. In 2005, the Federal Correctional held 21,702 inmates, where 268 of which were women. 70% of the offenders were serving a sentence for violent offenses like murder and sexual violations. There were 58.2% of federal offenders incarcerated, while 30.7% were under supervision in the community. 70% of the incarcerated offenders were Caucasians, while 16% of these offenders were from the Aboriginal group. Consequently, Canada remains in the mid-range of incarcerating countries. The second agency is the National Parole Board, NPB. It is responsible for the release, under parole, and revocation decisions pertaining to all federal offenders. Provincial inmates can apply for parole, and this application will be forwarded to the National Parole Board for all provinces except Ontario and Quebec. The 2 provinces mentioned have their own provincial parole boards. Now, let us get a glimpse of the Criminal Code of Canada according to Axon-Fagan 2007. Offenders may be eligible for statutory remission, where they can be released after serving a third of their sentence. Some may be released even before the statutory release date and be on day or full parole. However, statutory remission may be partially or fully lost when the offender misbehaves and can even be detained beyond the statutory release date or until their sentence is fully served, if deemed that the threat to the public is foreseeable. Federal offenders who receive statutory release are supervised in the community until their warrant expiry, but this does not apply to provincial offenders. Death penalty was abolished by the Canadian Parliament in 1977, and in fact, there were no prisoner executions since 1962. Let us look into the mental health issues in the Canadian corrections. Service 2010 cites from many authors that mental illness is more prevalent in the population of offenders compared to the general population of Canada, and this prevalence has significantly increased over recent years. According to the data from Public Safety Canada and Standing Committee on Public Safety and National Security, as cited in Service 2010, there are 11% of federal offenders diagnosed with mental illness, and this had a 71% increase since 1997. There are 21.3% of these offenders who are receiving prescribed psychiatric medications. 6.1% received outpatient services prior to incarceration, and 14.5% of male offenders were previously hospitalized for psychiatric reasons. 8 categories of mental health issues prevalent in Canadian prisons were provided by Accent Fagan, 2007. These are the following in chronological order. Number 1, antisocial personality disorder at 56.9% to 74.9%. Number 2, alcohol-related problems at 47.2% to 69.8%. Number 3, anxiety disorders at 44.1% to 55.6%. Number 4, substance-related problems at 40.9% to 52.9%. Number 5, depressive problems at 21.5% to 29.8%. Number 6, psychosexual disorders at 21.1% to 24.5%. Number 7, psychotic disorders at 7.7% to 10.4%. Number 8, organic disorders at 0.1% to 4.3%. In addition to these statistics, offenders are also likely to experience other problems that can worsen or increase the risk to mental illness. Offenders' adjustment to community life can be difficult, particularly for those with mental disorders. Thus, helping offenders manage their mental illness will help improve their functioning and provide a better environment for both the inmate and the staff working with them. However, Accent Fagan 2007 mentions that there are greater barriers posed for offenders trying to access psychiatric services.
According to Canada's Correction and Conditional Release Act of 1992, the improvement of an inmate's mental health functioning is central to the goals of incarceration. The World Health Organization further supported this argument by its statement that one of the goals of incarceration is to assist inmates in recognizing their abilities in order to help them improve their coping strategies related to the normal stresses of life, to work productively, to contribute positively to their families and communities, and to avoid a return to criminal behaviors. Some of the interventions which are targeted for prisoners with mental health problems are: the first one is intake, screening, or assessment. The second one is primary care. The third one is tertiary care. The fourth one is rehabilitation and discharge planning. And the fifth one is community care under warrant. So for intake, screening, and assessment, the computerized mental health intake screening system, or COMHIS, is a specialized mental health screening tool involving the administration of psychological tests to consenting offenders as they enter the prison system. It is designed to support the clinical screening and assessment function, provide information for the correctional plan, help identify offenders at risk, and provide standardized data for planning and evaluation. This is an important step. The data will be very useful in addressing offenders' health needs and planning the comprehensive mental health continuum of care. So next will be rehabilitation and discharge planning. Ideally, the discharge planning in correctional institutions is ongoing, consistent, and comprehensive. Prior to discharge, offenders are connected to appropriate community resources to help them fully reintegrate back to the community. Regarding community care while under warrant, the Correctional Service of Canada, or CSC, estimates 26% of offenders living in community correctional facilities have mental health problems and disorders, while 23% take psychotropic medications. Research shows that the adjustment to community life can be difficult to offenders with mental disorders while they are on parole. Under the Community Mental Health Initiative, or CMHI, they are provided with services designed to help them adjust to the life in the community, thereby reducing their risk of reoffending. Let's go over some of the challenges in delivering mental health services in prison. Some of the challenges we were able to identify are the following: turnover of the population. The next is stigma and an undersupply of mental health professionals across Canada. And the last one is the lack of inter-service connectivity. For the turnover of the population, the constant influx of offenders with mental health issues being incarcerated means less efficient and responsive mental health care services that can address the individual needs of the offenders. This results in inmates with untreated mental disorders being more likely than other inmates to engage in problematic behaviors, thereby serving longer sentences in jail. For the stigma and undersupply of mental health professionals across Canada, this make securing access to non-CSC professionals and programs even more difficult. For example, family physicians are in short supply and sometimes they don't want to accept offenders in their practice. Moreover, some non-CSC community-based mental health programs and services won't accept referrals except that from the family physicians. As a result, offenders are often left in limbo. The last is the lack of inter-service connectivity. The lack of inter-service connectivity means lack of intermediate care, which may serve as a vital connection between primary care and tertiary care. This puts increased pressure on the already overstretched primary care services and RTCs. Because of this, segregation and segregation-like units have become de facto intermediate services to some of the most behaviorally disordered offenders. Some of these inmates are denied admission to the RTCs, so are the responsibility of their maximum security level home institutions, where the primary care services are not equipped by definition to handle their level of healthcare problems and needs. Offenders are often isolated for long periods of time as security measures or for their own safety.
Hi everyone, I'm Leslie and I will be reporting about the future directions of managing prison population. First, I'm going to show you the social trends that caused changes in correctional environment. First, the advent of new antipsychotic medications in the 1950s released individuals with serious mental health problems from mental hospitals to the community, gave rise to community-based treatment programs, but increased the number of seriously mentally ill individuals in prisons and jails. Second, the war on drugs was started to address the failure of drug treatment strategies to adequately curb substance abuse, reducing drug supply entering the country, but increased numbers of substance abusers now found within prison and jail populations. Third, a series of Get Tough on Crime legislative initiatives were enacted, such as abolition of parole, the introduction of determinant and mandatory minimum sentences, and changes in standards defining criminal competency and responsibility. These initiatives have resulted in increased rates of incarceration and increased numbers of offenders, especially those with violent backgrounds, being incarcerated for longer periods of time. Fourth, according to Harrison and Beck, the number of foreign-born individuals in correctional systems is poised to grow even higher in the near future, fueled by the war on terror, as well as possible changes to current immigration laws. As a result, there have been growing numbers of individuals incarcerated for terror-related activities because of the subsequent terrorism attacks. Collectively, the social trends have significantly changed the composition of the correctional environment. It is now far more heterogeneous and complex, since it is consisting of greater numbers of dangerous individuals who are serving lengthy prison sentences with no chance of parole. Each of these groups brings its own sets of challenges for correctional administrators and mental health professionals tasked with addressing the diverse and competing needs of these groups. Next, I'm going to show you the efficient ways of managing diverse correctional populations. Increase cooperation and integration among criminal justice and community agencies. Taxman, Young, and Byrne suggested several strategies for increasing effectiveness of correctional treatment programs as follows. Treatment programming should begin at the start rather than during the last phase of incarceration, and that the emphasis of programming be on motivating offenders to change their criminal thinking to non-criminal, pro-social thoughts and choices, and on developing good employment skills. Offenders should be moved as close to their re-entry location as possible to promote contacts with community resources and their family members. Inmates should play a more active role in planning both their corrections-based treatment and their community re-entry. Introduction of integrated offender programs includes faith-based initiatives wherein religious groups were involved in improving conditions of offenders during their incarceration and in easing their transition back into the community by offering spiritual guidance. Vocation preparation programs are the prison-based educational, vocational, and the on-job trainings that prepare offenders for employment success upon release. Next is increased focus on high-risk, high-need offenders through provision of extensive community-based services such as crisis intervention strategies, financial assistance, medical management, counseling, and other advocacy services to offenders by trained community professionals via team approach. Development of programs that will address the needs of the large number of incarcerated individuals with substance abuse problems and to identify which programmatic features are most effective with this population. Collaborative and integrative programs for targeted individuals with chronic medical conditions such as HIV. This can be done by providing a range of medical services such as education about STDs, disease and medication management, vaccinations, and other routine care. Program efforts includes drug courts, which is a way of diverting nonviolent misdemeanant substance abusers away from prison and connecting them with community treatment services. Mental health courts are designed to divert misdemeanants found to be mentally ill into the community treatment programs rather than correctional institutions.
Hi everyone, my name is Leah, and I will be talking about treatment initiatives in Canada. Overrepresented in Canada's correctional facilities are populations with high rates of mental illness like depression, psychosis, substance related disorders, and anxiety. It is a correctional jurisdiction's mandate to manage complex populations with different needs, which includes those who have mental illness. Mental health strategy for corrections in Canada includes two parts. These include the framework and the strategic priority. The framework ensures that an emphasis is placed on providing an opportunity to engage individuals in the correctional systems with mental health problems, to develop and implement new treatment plan, to integrate the mental health services received in correctional settings with community-based treatment and follow-up services, and to ensure continuity of established treatment plans. The framework establishes the foundation for the strategic priorities as described for each of the seven key elements. The first one is mental health promotion. The effective delivery of mental health services along the continuum of care is realized in an environment that promotes wellness, prevents illness, and makes active efforts to reduce stigma. This includes information for individuals within correctional system, information for staff, and support network. The third key element is treatment services and support. A range of appropriate and effective mental health treatment and adjunct services is essential to alleviate symptoms, enhance recovery and well-being, enable individuals to actively participate in correctional programs, and for safer integration of individuals with mental health problems into institutional and community environments. This includes information about services, staff qualification, treatment plan, mental health and substance use services, access to medication, emergency services, environment, and equivalence of care. The fifth key element is transitional services and support. Dedicated transitional services are required to support a seamless community of care from the community to the correctional system and upon return to the community. This includes transitioning from the community to the correctional system, transition plan for reintegrating into the community, and continuity of medication. The sixth key element is staff education, training, and support. Staffs require ongoing support as well as comprehensive education and training in mental health to enhance their well-being, knowledge, and skills to interact effectively and provide appropriate support for individuals with mental health problems. These include staff education, training, suicide prevention. The seventh key element is community supports and partnerships. Outreach initiatives to build relationships with partners are essential to optimize individual mental health and well-being, enhance continuum of care, and contribute to the shared responsibility of public safety. This includes correctional, government, and non-government partners, and developing community capacity. The strategic priorities, on the other hand, identifies all priority areas over the next 5 years to improve all jurisdictions' performance against the key elements in the framework. This includes knowledge generation and sharing, enhanced service delivery, improve human resource management, and building community supports and partnerships.
Hello and good afternoon, everyone. Good afternoon, Joyce. My name is Israel Akinade, and myself and my group mates, we have been discussing mental health issues in the prisons. For us to understand mental health issues, we have decided to review certain topics which include the history of mental health in the prisons and the causes of mental health. We also looked into Canadian corrections, delivery of mental health, future direction for mental health in the prisons, and we also looked at treatment initiatives. And I will be here to discuss on the conclusion and recommendation. Mental health issues in the prison is something that has been around for a very long time, as far back as the 18th century. And several efforts have been made to understand how this process can be made better, how mental health of prisoners can be improved. Several recommendations have been put forward to improve mental health issues in the prisons, and these recommendations include improved communication, cooperation, and collaboration. Improved communication and collaboration between agencies or parastatals involved. It goes beyond meetings. It has to be understood by all the parties that are involved, and everybody has to come to the table, agree, and have goals. And this is one of the ways to improve mental health in the prison. Another recommendation is the use of risk assessment. And on the risk assessment, it is very important to use the risk assessment for identifying treatment needs rather than using it as a means of punishing the offender. Also, allowing prescriptive authority to train psychologists so that they are readily available, and also adopting public health harm reduction approach. This is something that has been in use in the United States, and Canada is adopting that, like we see in Vancouver, and now we see that in Toronto. They're starting, which is a great thing. With people can go in, and they can. They have injection sites. They go there. They do exchange program, or they can even get condoms and things like that. And that has been a great initiative. Other recommendations listed includes conditional sentencing programs. In the conditional sentencing program, the offender is offered options, which includes to plead guilty and be directed towards rehabilitation rather than towards the prison. And of course, it has to be acceptable to all parties involved. Also, the amnesty programs, which aims to reduce the number of offenders going into the prisons and also increase the number of offenders that have been, prisoners that have been released. Also, the WHO mentioned the use of empirical data in decision making. Promotion of good mental health is something also that is very important, and these aim at early detection, treatment, and also health promotion. And also there is diversion towards the mental health system. Finally, on recommendation, provision of general health services should be made available to prisoners, and this should include early assessment and treatment. And the prison workers can be very helpful in providing these services, and also the community workers can make regular visits so that these can be achieved. Also, high standards in prison management, human rights and justice should be upheld, prevention of discrimination as well. And also information should be provided to prisoners and their families, as This will help to promote mental health and help with early detection and also prevent or reduce stigma and discrimination as well. And finally, uh, train correctional staff on mental health issues and promotion. And these also help to reduce stigmatization and promote mental health. Thank you.
Now let's have a look on our list of references and image sources. Thank you so much for watching our presentation.